Neurovision technology in improving vision in adult amblyopia. There is no financial interest. The aim of my study was to evaluate the efficacy and safety of revital vision in improving visual acuity in patching-resistant amblyopic eyes of patients older than 9 eye. As we all know, amblyopia develops as a result of abnormal visual experience during the sensitive period, although the exact neural mechanisms of amblyopia are still unknown, characterized by several functional abnormalities in spatial vision, including a reduction in visual acuity, contrast sensitivity, vernier acuity, as well as spatial distortion. Revital vision therapy is an FDA-approved, non-invasive, patient-specific perceptual learning software program based on visual stimulation. It facilitates neural connections at the cortical level through a computerized visual training using Gabor Patches to improve contrast sensitivity and visual acuity. How does it work on the brain? The Gabor Patches are considered to be the most effective visual stimulation as it matches the shape and orientation of the primitive receptive cortex fields of neurons in the primary visual cortex and therefore effectively activates them. So this therapy uses the Gabor Patches to stimulate the neurons. The neurons in the primary visual cortex are selective for the size, orientation, and direction of motion of patterns falling within the restricted region of visual space known as the receptive field, and each individual neurons respond to the precise location, orientation, and spatial frequency. And this software uses different types of Gabor Patches to stimulate different neurons based on their spatial frequency, orientation, contrast, target flankers, and displacement. To characterize an image, visual processing involves cooperative activity of many neurons, and that is lateral interactions. So this is what they make use of it. They tried either using the Gabor patch alone or the Gabor with the flankers and Gabor without the flankers, and they found the maximum neural electric response when the Gabor patch along with the flankers were used, and this was what was used in this software. The exercise becomes harder until where the patient can't see the target Gabor and can't identify the correct display from the two options and makes a mistake. So enhancing neuronal lateral interactions by perceptual learning technique. What it is? Repetitive performance of specific visual tasks. It stimulates the specific neurons and effectively promotes spatial interactions among these neurons. And enhanced spatial interactions will reduce the noise level, increases the signal strength, thereby improving neuronal efficiency, inducing increase in contrast sensitivity function, and thereby improvement of visual acuity. It is a personalized visual stimulation, that is, two computerized assessment analyzes the patient's specific cortical defects by measuring the patient's sensitivity to different types of visual stimulation and the specific threshold level. Based on the assessment, the software targets specific neurons, providing optimal visual stimulation. So it's a computer-based program. It can be performed in the center, clinic, or home. It is personalized. It is formed among proprietary algorithms. After baseline investigation, 2 computerized evaluation sessions. It is a 40 training session, 30 minutes each, 3 times a week, and follow-up exams after 10, 20, 40, and completed after 40 training sessions. So the study and protocol conform to the tenets of Declaration of Helsinki after informed consent. All patients underwent at least 6 months of patching therapy with no visual improvement prior to starting this neurovision therapy. The exclusion criteria consisted of any other condition or cause of reduced visual acuity other than anisometropia, ametropia, amblyopia due to strabismus, visual deprivation, and nystagmus. A baseline examination included best-corrected visual acuity, contrast sensitivity, detailed anterior segment evaluation, and fundus evaluation. All the cases in the study then underwent an orientation guided by the trainer. So 55 patients were there. 9 patients had to drop off because of compliance, and we included patients who complied with minimum training, that is at least 25 training sessions out of the 40 required, at least 10 sessions per month out of the 12 to 15 required. So this is an example of a complying patient, and this is a non-complying patient who dropped out of the therapy. So this prospective study comprised of 45 patients aged between 8 to 48 years of age, of which 39 had amblyopia due to refractive error, 3 had visual deprivation, 2 cases had nystagmus, and 1 had strabismus. All had undergone patching prior to revital vision therapy. The main outcome was a best-corrected visual acuity. This is the distribution of the cases based on the etiology of the patients, and we had 22 females and 23 males who were included in the study. This was the average visual line improvement. On an average, there was 2-line visual improvement among these 45 patients, and as the age advanced, the visual acuity line improved. So this is the graph showing the visual acuity improvement. In conclusion, our study is the first prospective study in India to report the efficacy and safety of this novel non-invasive perceptual learning technique program called as the Neurovision therapy or Revital Vision. Our study confirms current published data of enhanced best corrected visual acuity of 2+ lines in adult amblyopic individuals not responding to traditional patching therapy. The limitations of this study include the absence of a comparative control group and a small sample size. Preliminary evidence suggests Revital Vision or Neurovision therapy technology perceptual learning treatment is safe and improves best corrected visual acuity in adult amblyopic patients